In neurosurgery, there is a rumor that the right hemisphere is the non-eloquent hemisphere. And what they mean by that is that it's not the hemisphere dominant for language. However, there are many functions of the right hemisphere that are very important, as you all know, in communication and thinking. It's very important for selective and sustained attention and integration of information, getting to the gist in narratives, getting to the point, staying on topic, detecting relevance, understanding humor and irony, understanding multiple meanings of words. It's also very important in understanding affective prosody and facial expression. Many of you know that your left hemisphere patients have difficulty with the words, but their prosody, at least their affective prosody, is fabulous. So they can convey a multitude of meanings with just prosody and facial expression and no words. So you've all had Wernicke's aphasic patients who say, na 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 na, and you know basically what their emotions are, even if you have no idea what they're saying. And right hemisphere patients are often the opposite. They may say words and sentences that are accurate, but the prosody or tone of voice is incongruent with what they're saying. So they may say, I had a fabulous time. And you don't know if they really did or if they're being sarcastic or what. It's also very important in viewer-centered spatial attention. So lesions of the right hemisphere often cause hemispatial neglect. I will not be talking about that today, except to show you that deficits in prosody are actually more common than deficits in neglect, or than neglect is after right hemisphere stroke. But if you ask any neurologist what the cognitive deficits are after right hemisphere stroke, they'll only mention neglect, because that's very obvious. You kind of see it as soon as you walk in the room. And prosody is a little bit less obvious, but more common and commonly impaired. So my objectives will be to discuss deficits, first of all, in discourse after right hemisphere stroke, and provide some evidence that impaired prosody may be a particularly sensitive marker of right hemisphere stroke, and show how hypoperfusion or infarct of specific brain regions can result in different types of impaired emotional prosody recognition and production, and then discuss some deficits in recognition of emotions from facial expression after right hemisphere stroke, if I have time. So you all know this picture, and I'll show you, we have an updated version of this picture, but this is the cookie theft picture. And Yorkston and Buchelman many years ago asked 31 healthy controls to describe the picture, and then reported the content units that virtually all the healthy controls say about this picture. Most people say pretty much the same things. They may add a little more detail or a little less, but everybody talks about the boy and the girl stealing cookies, he's falling off the stool, mother's washing dishes, water's flowing over the sink, she's not paying attention. So content units are words or their exact synonyms that have a particular meaning. So it may be a phrase like falling off, falling over, tipping over. All of those have the same meaning, and that would be a single content unit. If they say the same content unit like mom, mother, mama, those only, or even the same word over and over, it only counts as once. So we also have used these same measures of looking at content units and syllables per content unit to describe deficits in right hemisphere speech, because people with right hemisphere stroke typically say a lot of things that are accurate about the picture, but not necessarily the same thing that healthy controls show, and I'll talk about, and I'll show you that. But also they produce more content units in more syllables per content unit, because they get off on a tangent, they're digressive, they start talking about other things irrelevant to the picture. so they have inefficient speech, is indicated by increased number of syllables per content. Now, aphasic patients may do that too, but for a different reason, because they're trying to think of a word, so they're very circumlocucious and so on. This particular picture is now part of the Nih Stroke Scale. So it's given to every stroke patient in the country and most of the worldwide, where they ask people to describe the picture, but it's not quantified. It's just used to say, well, this patient's aphasic or not. So this is a patient of mine when I was a speech pathologist who described this picture, and this is pretty typical for what we sometimes see in after right hemisphere stroke. He said, well, it's on 8.5 by 11-inch paper, overall covered by plastic. It looks like it may have been done with drawing pens and India ink on white paper. It's less than 20-pound paper, else you wouldn't have used black to keep it from shining through. And then I said, no, tell me what's happening in the picture. And he said, oh, I see a window and curtains someone pulled back, hospital-type curtains exposing a window and utensils on a table, pan or a pot, curtains tied back with strings tied, kitchen curtains, no particular design. The rest of the curtains only called curtains because the overall lack of color. There is evidence that the paper was punched out for a 3-ring binder. The room seems to be filled with air because the curtains have a billowing effect. So none of these things are inaccurate, except maybe a little illogical about only called curtains because of their lack of color, but not really inaccurate. But these are not things that healthy people say about the picture. They don't talk about air in the room. They don't perseverate on the details of the curtains. You may notice he didn't mention anything on the left side of the picture. He's also just not getting the main idea. Whereas an aphasic patient may not have many words, but they'll say, oh dear, oh no, bam, disaster. They get the big idea. It's a disaster going on. So this would be, very high in syllables per content unit. So we decided to quantify this measure to see if it could accurately capture the volume of stroke in both left hemisphere and right hemisphere stroke, and also if it could distinguish healthy controls from stroke patients, and maybe even tell us about the site of lesion in left or right hemisphere stroke. So we tested, in our initial paper, 26 patients in each group, matched for age and education, and asked them to describe this picture. And what we found is left and right hemisphere stroke patients were both equally impaired in the number of content units produced about the picture compared to controls. In terms of syllables per content unit, both left and right hemisphere patients were fairly inefficient compared to controls. They produced a lot of syllables per content unit. And the ratio of left content units to right content units was a nice measure of hemispatial neglect, very quick measure. And because in both left hemisphere patients, they showed right neglect acutely, and right hemisphere stroke patients showed left neglect and produced a low number of ratio of left to right content units, whereas healthy controls produced about equal number of content units on both sides of the picture. So this is basically just what I showed you, said to you, but it shows you the statistical significance was very high. The total content units actually negatively correlated with lesion volume in both left hemisphere stroke and in right hemisphere stroke. And the total content units correlated with a percent damage to right incident cortex. Interestingly, the correlation with lesion volume was as good as the entire Nih Stroke Scale alone. So it is just giving this, quantifying this one picture, it can give you as good an idea of the size of the lesion as giving the entire Nih Stroke Scale, which is tests of motor function, sensory function, perception, and so on. We also found that syllables per content unit correlated with percent damage to some specific areas, including in the right hemisphere, the right homologue of Broca's area, right angular gyrus, and right superior temporal gyrus. Total content units also correlated with a number of these areas on the right. And the ratio of left to right content units, so having a low ratio, correlated again with percent damage to the right IFG, right middle temporal gyrus, and right inferior temporal gyrus. So then more recently, Erin Meyer, and I'm stealing a little bit of thunder here, so I'm not going to go into detail, but she's going to hopefully be presenting this at a clinical aphasiology conference. She's been looking at increases and decreases in functional connectivity in resting state fMRI associated with the language or in functional connectivity in the language network, the Salience Network, and the dorsal attention network that are associated with measures of narrative speech using the cookie theft picture in left and right hemisphere stroke patients. So we were interested in the Salience Network because this is a network described really in frontotemporal dementia patients. It's a network that is atrophied. Bill Seeley's work shows this in frontotemporal dementia patients, but they have a lot of similarities, especially the behavioral variant frontotemporal dementia with right hemisphere stroke, because it's mostly a right temporal, frontal and temporal atrophy or degeneration syndrome. And they often produce this digressive speech, they don't get to the point, and so on. And he describes this network important for figuring out what's salient, what's important. And they're impaired in that. So we thought possibly right hemisphere stroke patients might be as well, and it might correlate with syllables per content unit. And what she found, and this is Erin, is that in the left hemisphere group, greater connectivity of bilateral temporal and parietal regions within language network was associated with production of more content units, reflecting language skills. And in the right hemisphere group, increases in some areas of connectivity and decreases in other connectivity between nodes of the Salience Network was associated with syllables per content unit, again, reflecting communication deficiency. So this is evidence that maybe this Salience Network is very important for narrative speech in right hemisphere stroke. Melissa Stockbridge, another one of my postdocs, looked at measures of cohesion in narrative speech, and that's use of language to refer to content across sentences, such that a sentence's meaning can only be fully understood in relation to other sentences. And it relies on the appropriate use of parts of speech, such as pronouns, determiners of noun, restatements to convey clearly and unambiguously that the reference to something outside of the sentence has occurred. So you might say, Joe is in the park, he is playing lacrosse, and everyone knows he refers to Joe. And if there's errors in that, that's an error in cohesion. And she found that acutely, people with left hemisphere and right hemisphere stroke, and this is Melissa, had similar impairments in the use of cohesive markers. Chronically, only those with right hemisphere stroke tended to sustain breakdowns in cohesion from sentence to sentence, not resolving the incorrectly chosen pronouns or ambiguities that were left in their sentences or in their samples. So now I'm going to go on to talk about affective prosody. We've talked about some problems with narrative after right hemisphere stroke, but affective prosody is the recognition and expression of emotion through voice, through changes in pitch, rate, loudness, stress, and rhythm of the voice. Interpretation and use of prosodic elements is really crucial for everyday communication and interactions. You can imagine that there can be a lot of misunderstanding between communication partners if they don't understand when you say, something like, I wouldn't do that, versus I wouldn't do that, versus I wouldn't do that. And so there are a lot of, your meaning is conveyed as much as by how you say something as what you say, and how many times have you said that to your partner. It's not what you said, it's how you said it that made me angry. So there's a dominant role of the right hemisphere in processing emotional prosody, and this has been shown by event-related potential, Fmri studies of right hemisphere activation during prosody judgments, and lesion studies. And even in some dog studies, they showed dogs' right hemisphere is important in their understanding of your tone of voice. And they, of course, can communicate very well by tone of voice. They understand when you're saying, good dog. Or even if you said, bad dog, that was a terrible thing to do, your dog would wag its tail. So they understand your prosody. However, the lesion studies and imaging studies have shown there's actually probably an equal role or even a dominant role of the left hemisphere in linguistic prosody, but not emotional prosody. So affective prosody comprehension is more impaired in patients with right hemisphere stroke compared to people with left hemisphere stroke or controls. As I mentioned, that's not the same for propositional or linguistic prosody. But we hoped that studies of patients with acute right hemisphere stroke might be able to help us identify areas of dysfunction or ischemia before reorganization or recovery, and identify dysfunction. When in our studies, we identify dysfunction at the same time as testing prosody. So we look at MRI scans of both diffusion and perfusion imaging, which shows areas of low blood flow, to identify the areas of dysfunctional tissue associated with the deficits at that time. And we evaluate lesions in people with and without the deficit of interest so that we can carry out statistical analyses. And this reduces the bias created by the fact that some areas are infarcted more frequently than others. So this is the imaging that we do. Diffusion-weighted imaging shows areas of ischemia or infarct, dead tissue basically, within minutes to hours after stroke. But around that dead tissue, there's typically a penumbra or area of dysfunctional tissue that's getting enough blood to survive, but not enough to function. So in this case, this area in blue is the whole area of dysfunctional tissue, and this patient has a lot more deficits, particularly in neglect and prosody, than would be explained by the small lesion here. So in our first study, this is Chinar Dara, who was a postdoc of mine, who looked at the incidence of aprosodia, or prosody comprehension problems, in right hemisphere stroke compared to neglect. So we used a test of impaired recognition and affective prosody that was developed by Elliot Ross. It's and I'll tell you a little bit more about that. And we compared it to a battery of neglect tests, as well as the Nih Stroke Scale, which I already mentioned. The test, and we hypothesized that this test of recognition of affective prosody might be able to more accurately distinguish right hemisphere stroke from controls than either the Nih Stroke Scale or the battery of neglect tests. So we studied 28 patients with acute right hemisphere stroke, and they were age matched and education matched to controls with normal MRI and normal neurologic exam, but who had a TIA basically and were hospitalized. So there's the same kind of patients as the stroke patients. And they got this battery of neglect tests from our lab that includes things like copying a scene, as you can see here, and a gap detection test where they have to circle all the circles that are complete here, and they put an X on a circle that has a gap in it. And some people neglect everything on the left side, whereas people with a different type of neglect respond to things on the left or right, but they don't see the gaps on the left side, so they circle that. The test of prosody comprehension was from the Prosodia battery by Ross, and it has it's an emotional categorization task with 6 different emotions, and the patient will hear a neutral sentence, like "we went to the other movies." It's a content neutral sentence, but it's said either in an angry tone of voice, a happy tone of voice, a surprised tone, etc. So we went to the other movies versus we went to the other movies. Or they hear monosyllables in different emotions. So ba 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 versus ba 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 ba. So they also got the Nih Stroke Scale, and then we carried out receiver operating curve analysis to determine which tests could better distinguish stroke patients from neurologically normal controls. And what we found, the prosody score, and this is just prosody recognition, had an area under the curve of 0.84, which is really quite high. The overall error rate of more than 31% on the prosody comprehension battery had a sensitivity of 92.9%, which is really good. Not a great specificity, but it correctly classified essentially 80% of the patients as stroke versus control, which was not significantly different from the entire Nih Stroke Scale, and it was better than the neglect battery or the item of neglect on the Nih Stroke Scale. So the neglect summary score from our whole battery had an area under the curve of only 0.57 and correctly classified only 56% of the controls. So we were right in believing that prosody was really more sensitive. And this just shows you the area under the curve. And this just shows you the correct classification for each of the tests. And the whole Nih Stroke Scale and the prosody battery were essentially equal. The Nih Stroke Scale was a little more specific, but the prosody battery was more sensitive. And so this is a common deficit in acute stroke patients. It's not always picked up at bedside, but now that I've gotten our residents to listen for it, they see how common it is, and they say, yeah, she really has no emotion in her tone of voice or in her facial expression. So one of the things that we've reported before is neglect is really only common after right hemisphere stroke in older patients. So in younger patients, they typically don't have neglect. In fact, kids with hemispherectomy tend not to have any neglect even after you take out the whole right hemisphere. So in conclusion, impaired recognition of affective prosody is more sensitive marker, not necessarily more specific, of right hemisphere dysfunction than hemispatial neglect, and it can negatively impact social interactions. So it's important to be aware of it. So then Amy Wright in my lab was interested in identifying cortical areas where infarct is associated with impaired recognition and expression of prosody. And she hypothesized that there would be a double dissociation between the impairments of expression and recognition, but also that specific areas of infarct would be associated with expression and or recognition impairments after right hemisphere stroke. So again, participants were tested on recognition of emotional prosody using the test I just described, and expression was evaluated by measuring the variability in fundamental frequency of their narrative speech. So we used the coefficient of variation of fundamental frequency, and then carried out voxel-based symptom mapping to identify areas of ischemia associated with severity of deficits in both of these. Inclusion criteria are pretty standard. Participants were average age of about 58. 15 out of 23 acute right hemisphere stroke patients, again the majority, had recognition or production deficits in affective prosody. 9 had impaired production of affective prosody as well, and 2 of these, the deficit was selective to expressive prosody. So 9 patients had both, but 2 had only expressive prosody problems, and 6 had selective impairment in recognition. So there is a double dissociation, but they also frequently co-occur because the largest number actually had both. The lesion symptom mapping was done in people who had both impairments of recognition and production of prosody. And what she found was the hottest area was this anterior temporal pole, where lesions here or dysfunction here was strongly associated with severity of impairment in recognition and production. All patients with right temporal pole lesions had deficits in both expression and recognition of affective prosody. The 2 patients who had selective deficits in expressive prosody actually had frontal lesions, right frontal lesions, and patients with selective deficits in receptive prosody had posterior temporal lesions, caudate lesions, or thalamic lesions. So expression and recognition of prosody can be selectively impaired. Damage to right temporal pole is associated with impairment of both, indicating this may have an important role in a mechanism that's shared by expression and production of affective prosody. And in fact, in a previous paper, we had found, Chinar Dara, who I had shown you before, had found that right temporal atrophy, temporal pole atrophy especially, was associated with progressive impairment of affective prosody recognition and production in a patient with behavioral variant frontotemporal dementia. So this is this patient. In most of my lesion studies, the right hemisphere is on the left, and the areas in blue show areas of greatest atrophy. The dark blue shows the areas of greatest atrophy in between 2 MRIs in the same patient, separated by 6 months. So you can actually look at which voxels got smaller in that patient. And in fact, the areas that got smaller in this patient were in the insula, temporal pole, and inferior frontal, orbital, inferior frontal gyrus, pars opercularis, and orbitalis. And so these areas seem to be important for both. She had the most remarkable flat tone of voice and remarkable impairment and recognition of prosody that I've ever seen. And it was actually one of her main complaints. She had a PhD, very smart woman, and she came to me saying, I just can't express my emotions. I feel emotions, but nobody thinks I do. My daughter doesn't think that I love her or care about her because I can't show her with my voice or my face. And it was really quite remarkable. And then Shannon Shepard in my lab decided to look more specifically at areas where acute ischemia is associated with impaired recognition of affective prosody, and hypothesized that recognition of emotion in speech relies on a right ventral stream area and limbic structures, including posterior superior temporal gyrus, temporal pole, inferior frontal gyrus, pars orbitalis, the orbital frontal cortex, amygdala, anterior cingulate, and sagittal stratum, which connects these areas. And she had acute right hemisphere stroke patients, again, mean age of about 55, half men and half women. And they underwent diffusion-weighted imaging, flare imaging, and susceptibility-weighted imaging, which shows any areas of blood. And technicians were blinded to the prosody results, traced the area of dysfunction, and then we looked at the lesion overlap maps in various groups, and then looked at percent damage to areas in the proposed right hemisphere ventral stream and underlying white matter structure that were associated with impaired recognition of prosody. And they list the participants listened to 24 pre-recorded semantically neutral sentences, like "I will be going home today," spoken with different emotions, and selected happy, sad, angry, etc. As the tone of voice. This is the lesion overlap, and it's basically a lesion overlap map that's similar for any acute stroke or chronic stroke population, where the most commonly lesioned areas are the insula. She found, very similar to our previous studies, that overall emotional prosody recognition was impaired in more than half of the right hemisphere stroke patients. Patients achieved a mean accuracy of about 57% versus controls achieved an accuracy of about 83%. And then we used multivariable regression to identify the percentage of 8 ventral stream areas where ischemia predicted the error rate in emotional prosody recognition. And she found that these ventral stream regions damage could account for about 52% of the variance in recognition of emotional prosody. Individual predictors of emotional recognition were older age and greater damage to posterior superior temporal gyrus. And that was pretty consistent with findings by Ross and colleagues, where they found that there's almost a mirror image in areas of the right hemisphere that are important for recognition versus production, as in the left hemisphere for recognition and production of language. And so this just shows you the results, and the independent predictors are shown here. So this is participants with posterior superior temporal gyrus lesions, and these are patients without these lesions. And you can see the patients with these lesions were had more errors in lower accuracy in recognizing all of the emotions except for surprised. And these are the areas where the percentage of voxels that are ischemic was associated with the error rate in prosody recognition. I already told you that's the posterior superior temporal gyrus, but this just shows you the map of that. We also did a multivariable linear regression model evaluating recognition for each emotion separately, but the only model that was significant was recognition of fearful prosody. And the damage to these ventral stream regions could account for about 76% of the variance, with an R-squared actually of 0.88 for recognition of fear. And the individual predictors of lower accuracy of fearful prosody were percent damage to the right amygdala and older age and less education. So here, this just shows damage to the right amygdala was associated with impaired recognition of fearful prosody. And the independent predictors were consistent with some previous findings. So older age, people get less accurate in recognizing emotional tone of voice, and also previous findings of the importance of the right posterior superior temporal gyrus in recognition of prosody, but also the percent damage to the amygdala is being important for fear is consistent with evidence from recognition of fear in faces. So lots of people know that people with amygdala damage are impaired in recognizing fear. Then this is Sona Patel, who is a colleague who's working with our lab, doing acoustic analysis of the patient's speech. So we were interested in identifying areas where acute ischemia is associated with impaired prosody expression. So we hypothesized that abnormal patterns of acoustic features in speech of right hemisphere stroke survivors correlate with the listener judgment of affective prosody and are associated with infarcts of specific right hemisphere gray and white matter regions. So the first thing that we did is identify 40 acute ischemic right hemisphere stroke patients who had MRs within 48 hours, and they just described the cookie theft picture, which is probably not the best stimulus for getting emotional tone of voice, but that's what we had. And then we identified acoustic features that correlated with listener ratings, and then used linear regression to identify independent predictors of those acoustic features using logistic regression. So we identified percent damage to each of 9 regions after registering the DWI to an atlas, and then identified lesions that are associated with abnormalities in important acoustic features, those that correlated with listener judgment. So of course, first we had to identify which acoustic features identified correlated with listener judgment of flat affect. And there are a million, I didn't realize this till I started working with Sona, there's lots of acoustic features that you can analyze in speech. But what she found was that listener ratings of prosody, and we had a couple of dozen listeners just judge whether the person sounded highly emotional, normal, or very flat, or unemotional. And so the listener ratings of prosody correlated with the duration of voice segments divided by the total duration of speech segments. So basically, what percentage of the speech signal is voiced, and spectral flatness, which makes sense, and also the variability in listener rating was best accounted for by 3 things, four. This duration of voice segments, spectral flatness, pitch range, and the fundamental frequency, the coefficient of variation in the fundamental frequency, which is the one we had used initially, in both women and men. We looked separately. And the low spectral flatness was predicted by sex, age, lesion volume, and percent damage to each of the 9 regions of interest. But the independent predictors were sex, lesion volume, damage to inferior frontal gyrus, pars opercularis, inferior frontal occipital fasciculus, and superior longitudinal fasciculus, as well as uncinate fasciculus. So mostly dorsal stream areas were associated with spectral flatness. Coefficient of variation of fundamental frequency was predicted by sex, age, lesion volume, and percent damage to each of the 9 regions of interest. This was highly significant again. Age and damage to the supramarginal gyrus and superior longitudinal fasciculus were the only independent predictors of variation in fundamental frequency. So again, dorsal stream regions are important for expression of prosody. Sorry. And then this low voiced to total duration was predicted by sex, age, education, lesion volume, and percent damage to each of the 9 regions, but there were no independent predictors. So sex is not too surprising. Women tend to have more variation in emotion in their voice in every study. Again, age is like recognition. There tends to be a little less coefficient variation in the tone of voice with age, and education, lesion volume in the right hemisphere is not surprising either. So impaired emotional expression after right hemisphere stroke is due to changes in specific acoustic features caused by infarct in pars opercularis, supramarginal gyrus, or the associated white matter tracts in the dorsal stream. And then Cameron Davis and Yesenia Gomez in my lab working with Kanoishi wanted to look at areas of acute ischemia associated with recognition of sarcasm. So sarcasm isn't exactly emotional affect, but it is something that tends to be impaired after right hemisphere stroke more than left hemisphere stroke. And it's hard to describe exactly how we know so well when someone's being sarcastic, but we really do. Healthy people are very good at that. So we hypothesized that because lesions in a variety of cortical regions can disrupt ability to recognize affective prosody, lesions to white matter tracts that connect nodes of the network should result also in impaired recognition of sarcasm. So the participants were about 24 patients with acute ischemic stroke, tested within 24 hours, and 24 controls. We tested sarcasm with the aprosodia battery by Ross, and there are a bunch of neutral sentences, like this looks like a safe boat, spoken with either a sincere tone of voice or a sarcastic tone of voice, like this looks like a safe boat. And so patients with our controls were asked simply to state whether the person was being sarcastic or severe. Sorry, this button is very sensitive. And then we use multivariable linear regression with percent damage to each of 8 white matter tracts. Age and education as independent variables, and error rate in sarcasm recognition as the dependent variable. And these are the 8 tracts. They're just outlined here to show you. And these are patients who had damage to each of the 8 tracts that we looked at. We looked at right fornix, stria terminalis, inferior frontal occipital fasciculus, posterior thalamic radiation, sagittal stratum, superior frontal occipital fasciculus, and superior longitudinal fasciculus, and uncinate. So the model with 8 predictors was statistically significant, but could only account for about 46% of the variance in sarcasm recognition. The error rate in recognition of sarcasm was best predicted by the degree of damage to the sagittal stratum, independently of the other variables. Patients with sagittal stratum lesions had lower accuracy rate than those without lesions to this white matter tract, so 22% versus 50% correct. And there was no difference between groups in age, education, or total error rate on prosody comprehension. So it seemed to be pretty specific to sarcasm. Percent damage to sagittal stratum was associated with error rate in detecting sarcasm in neutral sentences. And this is really a large bundle of white matter tracts or fibers that connect frontal, cingulate, temporal, parietal, and occipital to regions of the thalamus and other deep structures. So it carries both afferent and efferent fibers between the thalamus and the cortex. The thalamus is sometimes considered the gateway to the cortex for perceptual information. And then Amy Wright and others in the lab wanted to identify whether we could find people who had selective deficits in separate cognitive processes underlying affective prosody. So we came up with kind of a model based on kind of an information processing kind of approach, what cognitive functions should be necessary to recognize or produce emotional prosody. So for recognition, you really have to do acoustic analysis of the stimulus, but you also have to have some kind of stored representation of what each emotion should sound like in order to identify it. So somehow we and our dog and our horses and others have some notion of what angry sounds like or emotion, happiness sounds like. And it's developed very early on. So even babies know when their mother is happy or sad by their tone of voice. And so this is, it can't it probably isn't innate, and it's probably learned, but it is something that is represented. There's some kind of abstract representation of what each emotion sounds like. We also have to access to understand what the emotion is from sound. We have to access some kind of semantic representation. So what does sadness mean? What does happiness mean? And this can actually be impaired in people with behavioral variant frontotemporal dementia and even very large right hemisphere strokes, where they just really don't seem to have any meaning of happiness versus anger versus sadness, and are sometimes thought to be apathetic, but it's not necessarily a mood change. They just don't know what the emotion means anymore. And then to produce prosody, you really have to access that same abstract representation of acoustic characteristics that convey emotion. We've called it the air race. So for example, we know that sadness sounds like usually kind of low volume, slow rate, reduced pitch variation. You know, remember Eorin said, good day, if it is a good day, which I doubt. So this kind of, these characteristics are characteristics of sadness, but not happiness. And then to produce prosody, you also have to have motor programming of the speech articulators in order to change your voice pitch and so on, loudness and rhythm. So we evaluated 24 patients with acute right hemisphere ischemic stroke on batteries to identify impairment in each of these cognitive processes underlying prosody, and then identified a few patients who actually had selective deficits, and then tried to figure out where their associated areas of ischemia were. And one of the things that we found was that there were people who were impaired in perception and recognition of prosodic features, not just not that abstract representation of what things should sound like, but they really were impaired even in recognizing slow versus fast, high versus low pitch, quiet versus loud pitch. And we use this with abstract stimuli like, which is faster, beep, 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 or beep, 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 and so on. So you can do that with loudness, tone, pitch, and so on. And patients who are impaired in perception and recognition of these features had lesions or dysfunction, in this case, in right temporal cortex. So this patient has poor perfusion widely in right temporal cortex. Oops. Whereas impaired abstract representation of acoustic characteristics that convey emotions was tested by actually giving them emotion like sad and asking them to select features that go with that emotion. So they had to pick at least 2 of the features, quiet, slow, low voice, or monotone, to be accurate. And the 2 patients who had selective deficits in accessing this ARAS both had insular lesions, as you can see here. They're a little bit beyond the insula, but really the only 2 things these 2 patients had in common were insular lesions. And then one patient was impaired in the meaning of emotion, and this was tested with matching emotions to synonyms that are emotions like joy is matched with happiness instead of anger, and also matching situations to emotions like if this happened to you, if somebody stole your car, what emotion would you feel? They're pretty simple things. And this patient was impaired. And then execution of motor programming to produce prosodic speech was tested with repetition and reading of neutral sentences given prosodic features. So if we ask them to repeat a sentence with the same emotion, if they had trouble doing it, and even if we gave them cues to say, okay, you should sound should have a low pitch, you should be quiet and slow. They just couldn't really do that. And this patient had one patient had a right caudate area of hypoperfusion. And this is a bad scan, but the patient actually had a right IFG lesion. And then, so in conclusion, recognition of affective prosody is frequently impaired after acute right hemisphere stroke, and there are distinct areas of damage that result in impaired recognition, right temporal cortex versus production, sort of right dorsal areas like inferior frontal gyrus and supramarginal gyrus, or if they have both impairment in recognition and production, they often have right insular lesion. And there are distinct cognitive processes underlying affective prosody that may depend on distinct right hemisphere regions. And the implications are that it's really important to educate family members of people with right hemisphere damage, to tell them that, look, your loved one doesn't understand tone of voice. So if you're angry, you have to say, using words, I am angry. Or if you're sad or disappointed, you have to say, I am sad, I'm disappointed. Or they won't get it. They won't pick it up from your tone of voice. We should also explicitly train the patients to do the same, because if they can't produce affective prosody, they need to say that they're angry or sad to avoid miscommunication, and that family members should also avoid sarcasm because the opposite meaning may be understood. Also, in terms of treatment, there have been very few described treatments of affective prosody. There was one phase 1 clinical trial by Rosenbeck in 2004, but they only recruited a few patients or a small number of patients and never went on to a comparison trial. More treatment studies have been done in Parkinson's disease, so you know, getting people to be louder and slower and so on. But more treatment studies are needed. Shannon Shepard in my lab is developing a treatment based on cues that facilitate prosody production. So we hypothesize that patients will improve in prosody production with cues that depend on the cognitive process that is impaired. So impairment at the level of this abstract representation of acoustic characteristics that convey emotion should respond to cues telling the patient what the emotion should sound like. So if they don't know what it should, they can't access this representation for what happy should sound like or what sad should sound like, giving them cues might help. So they're given cues like slow, low pitch, monotone, and so on. So she studied 28 patients with with right hemisphere stroke and 16 with chronic right hemisphere stroke and 11 healthy controls, and asked them to spontaneously produce 24 semantically neutral sentences and given a particular emotion. And we calculated the pitch range and compared the pitch range between spontaneous and cued expression using ANOVA. And so a spontaneous would be, they're just given the sentence, she will be going home today, and told, say it in a sad tone of voice. The cued production, they're given these cues and asked, say it in a sad tone of voice. And what she found was there was a group by emotion interaction and found that right hemisphere groups significantly had reduced pitch range, particularly on surprised and happy. And expressive emotion prosody was impaired in about half of the patients, and half of those with impairment improved with cues. And patients who responded to cues improved from a mean pitch range of 55 to 64 hertz across all emotions. whereas controls actually showed worsening with the cues because it made it a more artificial task. The chronic time point, she found similar results, but only 33% of patients improved with cues. And so some patients do improve with cues, particularly if they have that deficit to the air race. But the response rate to cues was greater in the acute stage than in the chronic stage, which suggests that therapy might be required early on. It also shows us that it doesn't always spontaneously improve, that treatment may be effective. So I'm not going to have time to talk about recognition of emotion through facial expression. I will mention that Donna Tippett in my lab has looked at this and identified particular areas associated with impaired recognition of emotions, including right amygdala. And that was particularly true for negative emotions, angry, disgust, and fear in facial expression. And right insular lesions were again associated with impairment in recognition of facial expression. So I want to end just by thanking all the people in my lab. Here's some of us at a picnic at my farm. And here we are spelling SCORE, exclamation point. So SCORE Lab. And I'm happy to take a couple of questions.
So we do have a question from our room. You got to speak up, Stacy, because the mic here is going to pick it up. You can hear us, Argye?
Yes. Yeah.
Excellent.
I have a question about that last study that you went over about with the cues for prosody. Could you tell if there was any carryover in the patients who responded well to the cues? Because I'm wondering if in the heat of the moment when you're really emotional, I imagine it would be difficult to remember how to make yourself reflect those emotions on top of processing your emotional state.
So I think I heard that. You're asking, is there any carryover to emotional situations with these cues? And it's a great question. We haven't know yet. We're just beginning to develop a treatment for prosody. We have not instituted any treatment, much less measurement to other situations. But that obviously would be the goal. And we are trying to, Ali Durfee in my lab is making some more functional settings to evaluate more functional prosody. Both recognition and production. So that will allow us hopefully to measure that at some point.
I think what Stacy also meant was maybe there's and correct me if I'm wrong, is that the task is very difficult, and is it possible that in between getting the cue and having to perform the prosody, that some of the patients may kind of lose the gist of what they have to do? Is that? Oh, sorry, I'm completely wrong. I was wrong, Argye. You answered the question.
Okay. Well, maybe that's your question.
I was mansplaining.
Yeah. Well, it seems to be more difficult for controls than for patients, and that it just makes it more artificial for patients. But patients did get better with the cues, so they did seem to get the idea and be able to retain what they were supposed to do.
There's another question.
My question might be a little off base, but I'm quite unfamiliar with this work of right hemisphere and prosody in general, but is there any research on sign language prosody signing, and are those areas similar to what you see in prosody in spoken language?
Yeah, as far as I know, I am not aware of any research on prosody and sign language. I think most of the prosody and sign language comes from both facial expression and sort of abruptness of the signs. So if you're angry, you know, you'll have very jerky kinds of things. So I have no idea. We know that language, there are similar areas of the brain that are important for syntactic and semantic processing in sign language as there are in normal language. But it's a great question, something somebody could look at some point. But I think we have to leave this room because it's now 3 and somebody else needs the room. But thank you very much. Were there any quick write-in questions? I don't think so.
No, we don't have any questions online. I had a ton of questions, obviously, but I'll just
Okay.
I'll ask them another time, Archie. That's no problem.
Sounds great. Thank you. Bye-bye.
Okay. Thank you.